It works. Hi everyone, my name is Eline de Vries and today I will be presenting this together with my colleague Hester van Dorst. With other key colleagues we work as researchers at the National Institute for Public Health and the Environment. And now we're evaluating experiments with bundled payments in maternity care in the Netherlands. There are currently 8, 9 or 10. I missed the number, but well, we started with 6 in 2017, and it all started with a Pedistat report, and it showed that the perinatal mortality decreased over time, but now it's rather steady. But the Dutch perinatal mortality lagged behind, so there was a high urge to do something about that. And there was a high need felt by everyone to improve the quality of care and to avoid as much, of course, the perinatal mortality. So the Ministry of Health, or Dutch Ministry of Health, said, well, maybe it's very important to try and to collaborate more with each other, because we all have independent care professionals with midwives, independently working, and the hospital on the other side, all thinking differently about how care should be organized. So collaboration should be very important, and the ministry suggested all kinds of policies, among which to introduce the bundled payments for maternity care. And the whole idea behind it is that the financial accountability is somewhat shifted from the payer towards the group of providers, so that they feel the incentive to collaborate more, to increase efficiency, and also decrease the use of low-value care, and of course stimulate the use of high-value care. So in the Netherlands, in practice, it is necessary to create an integrated care maternity care organization, which we call now IMCOs for short, because it's a very long word. And now there are 2 buyers markets. And in the first market, there's negotiated with the insurer. The IMCO negotiates with the insurer for the bundled payments, and that is based on the healthcare standards. In the healthcare standards, there are agreements about the minimum standards of care, about the quality of care, and they negotiate about the tariffs they can put the claims on. And in the buyer's market too, the IMCO is translating that towards the independent care professionals, so the midwives, the hospital, the gynecologist, but also the community maternity care organizations. And together they are also the representatives of the integrated maternity care organization. So they are all represented in this IMCO, and from there they negotiate with the insurer in buyer's market 1. In the Dutch national model, there are 9 modules over 3 phases: the prenatal phase, the natal phase, and the postnatal phase. And it's possible for an IMCO to either claim 1 module or 4. 1 in case when a pregnancy unfortunately ends before 16 weeks, and 4 in case when a pregnancy is fully completed. So when there's just a normal pregnancy with no complications, you would have a regular claim. So a tariff is negotiated for that claim, a regular claim for the natal phase, and in the postnatal phase the same. And of course maternity care, that's the 4th one. So there's actually some risk stratification in those tariffs. In case of complex care, you can claim for the complex module, and in case of normal care, you can claim the tariff for the regular care. The National Institute for Public Health and the Environment was asked to evaluate these experiments with bundled payments. In 2017, the start of 2017, it started. So from then, IMCOs were able to get formed and could actually claim those integrated tariffs. And in our research, we try to evaluate those effects. But for now, well, it takes a long time to get all these data together and analyze them. So we expect our report with the first actual results in 2020. But before that, so what we did in the last year, in our report that was published in the end of 2018, we tried to focus on the differences between the intervention groups and the control groups to be able to select later on the right control groups to do the analysis with. So for that, we created a quite extensive data set, and we merged data from all kinds of sources. Data on the health outcomes and the quality of care of mother and child from Perinet, that's the data source it's called. And from Factus. Factus is a national institute that collects all the claims data from the insurers. And we were able to combine these data using sort of a platform from Statistics Netherlands. And in that way we could prevent that individual level data was traced back to the person itself, accounting for all privacy regulations. So that was very hard to do that, but it worked. I think we have created a nice data set. Actually, it's a sort of a virtual birth cohort, which can be that helps us in doing the final analysis. So we looked mainly for differences between the intervention and the control groups, but it's all pre-intervention phase. So we compared the IMCOs with the non-IMCOs, and actually those are future IMCOs, because in 2016 they were not IMCOs yet. But maybe there were some kinds of pre-intervention things Hester will talk about later on going on, and there were differences already between the groups. And we saw that the non-IMCOs and the future IMCOs, in spending on perinatal care, there was a difference over time. The trend is sort of similar. The first part of the plot shows that we had not data on the full pregnancy. That's why it rises in the beginning. You can see there's a difference. It's about 182 euros on average per pregnancy, but there is a difference. And this difference you also see in the utilization of things. For example, in Caesarean sections, you see that the non-IMCOs provide somewhat more Caesarean sections than the future IMCOs. So there's already a bit of a change there, a difference, I mean. But luckily we don't see any differences in health outcomes for the mother and the child. Those are combined adverse effects, adverse outcome index 4, but it shows no differences between the two. So that is good news, but it is interesting that we see differences between the future IMCOs and the non-IMCOs in the pre-intervention phase, in the perinatal spending and in the utilization of care, because you can see there's quite some difference, and it's very important to take that into account when selecting control groups for the final analysis. Hester will move on with the next part.
Yes, so of course there were very big changes, and we also wanted to understand a bit more on how these changes came about and what to think of them. You can maybe imagine that it's quite a daunting task to create this new IMCO, an integrated care organization, and implement such new contracts as bundle payments. Therefore, one of the questions we asked all the IMCO regions that started in 2017, what their motivators were. And the most important one, the top number one that came out, of course, was the strive to improve the quality of care. This is what drives all healthcare providers, but also the managers, and they really believe that the current system, and for them the previous system of fee-for-service, was an obstacle in continuing creating better integrated care, and therefore they wanted to take a deep dive into implementing bundle payments. Also common among the 6 IMCOs that started was a history of innovation in birth care. This was both in other healthcare innovations such as electronic patient filing and centering pregnancy, but also on economic basis. For example, community midwives and gynecologists would collaborate together in an economic setting by running an ultrasound business together. And this already created a large trust, but also really had a network already in terms of collaboration on an economic standpoint. Furthermore, an important part for community midwives to participate was at the beginning when bundled payments would have been introduced. This would have been mandatory by the ministry. This has changed over time. However, many midwives feared that their entrepreneurial independence would be drifted away, and therefore they wanted to enter the experiment to be able to shape the new system and show the importance, both economically and medically, of their independent position. So basically they really wanted to be able to show a different way of creating the network instead of being given a blueprint where their entrepreneurial independence might be compromised. And also all regions had visionary leaders who were convinced of the potential of the bundled payments for their region especially. So these 6 regions with these reasons all really took on and took the deep dive where of course a lot of processes came about. And the first year experiences were of course mixed. Importantly, almost all providers reported to feel very positive on the cooperation in the integrated maternity care organization. This cooperation was not only more committed, but also more structured and intensified. However, the regions where an integrated electronic patient file was not used yet, there was much unease on this and was really high on the agenda. The entire transition was very complex and time-consuming. This might be of the start phase. We don't know this yet because we're just exiting the start phase. But it was reported in interviews that a lot of attention went to contracts and governance of the IMCOs, and the quality improvement was somewhat lower on the agenda temporarily, and therefore the improvement processes lagged in time a bit. And only after a year or so, when all governance and contracts were set up, could continue. For all the regions, external expertise was very important. They brought about knowledge and to keep all the goals aligned from all the different healthcare providers at the IMCO. And last, negotiations with the insurer were quite tedious. Entire new connection had to be set up. However, this seems to be temporary in nature, as IMCOs report that the second year negotiations were much more quick. Something that came about in these negotiations was risk mitigation, both for the IMCOs and for the insurer. This is really to ease the transition on both sides and is often referred to as a safety net. And these kind of clauses were reported for all the contracts with bundled payments between the new integrated care organization and insurer. And there are 2 types that I would like to go over with you. One is a range for negotiations. What all IMCOs do is they keep double accounting of the old fee-for-service system. All the claims they would have made, they put in a different system on the side so they can compare them to the actual claim they make in the bundled payment system. And this information is also shared with insurers. And once they make this comparison, they have agreed upon a certain range. It can deviate. Once this deviation falls within this range, here the example is 4% deviation. So if it's only 1% lower, for example, there nothing is done. The IMCO wins or loses 1%. However, when the deviation between what would have been the claims in the fee-for-service system and what is the claim in the bundled payment system is deviated more than the agreed-upon range, insurers and IMCOs enter renegotiations to, for example, adjust tariffs that have been negotiated. A second one is benchmarking. So often too referred as an agreement that the budget is transferred neutral. However, what the standpoint of neutral is, so what the benchmark is quite different, especially when it's either an historic benchmark or a current benchmark. In this infographic, the left column shows the historical benchmark. So in this case, for example, 2016, in the fee-for-service system, all claims that have been made. Then a hypothetical middle column where of the double accounting, all the fee-for-service claims that would have been made in case the bundled payment system were not introduced. And then in 2017, the claim that is made based on the agreement. In the left upper quarter, when there is no efficiency gain, both the historical and hypothetical current amount of claims in the fee-for-service system is similar, as still the same amount of work is done. So for both comparing 2016 on the left with the bundled payment, the height of the claim is the same, or the amount of the claim is the same as on the right for a current benchmark. However, a change occurs when there is a change in efficiency. Here an example of an efficiency gain. When using the historical benchmark, the efficiency gain shown in purple as having done less services in terms of the fee-for-service system will still result in the same payment in the bundled payment system, as this is compared to historical data when the bundled payment was not in effect yet. So this means that the efficiency profit remains with the IMCO. When benchmarking is done with the current double accounting system, the current double accounting will be decreased because less services have been provided due to improved efficiency. And this will be the mark for the bundled payment, and thus the efficiency gain will not be represented in the double payment, the bundled payments. So we have now shown you some of the highlights of our report, and we will of course continue with our monitor, with our evaluation. On the quantitative part with the large data set, we're now very much looking into defining a good control group for effect analysis, and we will match based on the qualitative data that we get from interviews and focus groups. Moreover, we want to add to the data set more outcome measures up to 2 years for a project on the first 1,000 days that started at the Ministry in September. On the qualitative part, we will continue to follow IMCOs and also the new incomes that started in 2018 and will start in 2019, what their experiences are and how they develop as organizations. And we are very interested, for example, what integrated care now was made possible by bundled payments and how these quality improvements continue. And something we're in the close future we'll be looking into is the relationships the IMCOs develop with the healthcare providers, which was previously referred to as Bias Market 2. For now, I would really like to thank you for your attention. If you want to read more up on the monitor, the report is available in Dutch in this link, and of course we are very happy to take your questions. Thank you.
Well, Thank you very much for this really interesting presentation. I'm sure there are some questions from the audience.
Thank you very much for a really interesting and good presentation and some important work. I was just wondering about the perspective of the mothers and public opinion. Maybe it doesn't have a financial effect, but it could be just I don't understand the Dutch system. But did you look at this aspect at all between the control group and the others?
Well, of course, it's important to actually see what the mothers think of this, but it's very hard to explain what bundled payment actually does. So we try to set up a sort of a focus group and try to well, have a conversation about what does it mean for actual care delivery, if there are bundled payments or not, and how is that different than integrated care. If it's done right, you only see that the collaboration between the independent care providers is, well, better. But whether it's because of the integrated care that is better, and you don't know if that's the case because of the bundle payments or not. So we try to set up something like that, but it's a very, very important question, but it's also very difficult to get a good understanding of that.
Thank you very much. It's Leslie Thompson from Health Standards Organization and Accreditation Canada. I'm curious with your comments on the slide around the first year of experience, where you talked about the balancing kind of structure and contracts, that there was a lot of attention on that with, I think, the culture of the actual collaboration across the providers. Can you speak a little bit more about what parts of the change process maybe you got some lessons learned from to make sure it doesn't become too focused on contracts and structure and take away from the actual goals?
Yes, this was also brought about by our respondents in the interviews. I can go back to the slide. So of course there was a history of collaboration. So this was not something that was newly set up. In these regions, there were already visionary leaders and people knew each other and were working together. However, they found obstacles in the payment system when working on goals concerning integrated care, and therefore decided to go into a bundled payment system, and for that create an integrated maternity care organization, or IMCO, which required a lot of governance and knowledge on contracts. Because these were the first regions to do this in the Netherlands, there was a lot of development of know-how and what were the possibilities and impossibilities of the system. So in these regions there was just limited time of the professionals, what they could achieve in, for example, their work groups, which would normally be more focused on developing interdisciplinary protocols, for example, or interdisciplinary education for midwives together with gynecologists or pharmacists or other professions. So there was just, from the resources, there was a new task that was some of more resources were directed towards. However, this was the organizations were quite conscious that these resources were redirected, and they really needed, after a year and a half, more or less, when the governance was set up and the contracts were running, they needed to boost the energy of the providers again, because they are more intrinsically motivated because of the quality of care and not because of good governance. Of course, they understand that this is important. However, the intrinsic motivation comes from good care. So this was very conscious for them, and they also set some of the governance developments on another spot on the agenda after about a year and a half when everything would be running. Does this answer your question more or less? Perfect, thank you.
Other questions?
Thank you. Hello. I'm over here, sorry. This is just a question. My name's Caroline, I'm from Australia. Is general practice, this is my lack of knowledge of the Dutch system, but is general practice or primary care involved in the IMCO? Are they part of the bundled payment?
Okay. No, that's the easy answer.
Well, it's in the Netherlands, general practices are not really involved in maternity care. So they're community midwives, and those function as the first line normal care delivery begeleiders. Supervision of pregnancy, and when it's getting difficult, the hospital is responsible. So the general practice, well, I think some GPs now do, well, one or two, the number is very low in pregnancies they follow.
Yeah. Okay.
Yeah, Dirk Ruart from the Netherlands, Maastricht University. If pregnant women live in such a region, are they obliged to get enrolled in this experiment, or is there something like an informed consent? Is there a way out for them?
Well, in these regions, the bundled payment is the standard of care. However, in these regions, the pregnant women have all the choice of providers they want. Also, providers who are not in the IMCO organization or associated with bundled payment. Does this answer your question?
Yeah, sure. Thank you.
Hello, Nicu Fota of Cred Foundation from Romania. I have a question about the costs related to forming this IMCO, and especially about the new IMCO that comes to the system. So the investment cost of getting to this process is considered?
Thank you for your question. Do you mean something like transitional costs, or?
Yes.
Okay. Well, there was funding to start with. There's some kind of a transitional fee that is added to the bundled payments, which slowly decreases over time. But and there's also help from a sort of task force trying to help all these IMCOs setting up. They provide knowledge and well, keep it a bit of a track. So there is some kind of funding, but we also hear sounds that it could be more.
Thank you very much for the presentation. This goes a bit beyond that, because you mentioned initially that bundled payments are also being implemented in other disease areas. Could you comment on these areas and what the national plans are to roll it out to the whole spectrum of disease? What is the plan?
Well, in diabetes, it's well, there are also bundled payments, but it's mainly in the first line, in the, well, not hospital care, but primary care. Excuse me. So that's just all set up and rolled out now. And well, the government's trying to experiment with other disease areas, but we're now on a sort of a crossroad. We try to evaluate whether it has its beneficial effects. And it really depends a bit on the outcomes of the research, whether the government tries to roll it out more or not. We're not sure yet.
Well, thank you very much. Great presentation, and thanks for answering the questions so competently. I think we have